Good morning, good afternoon, good evening, everybody. I'm Karim Fizazi, medical oncologist from Institut Gustave Roussy here in France, also University of Paris-Saclay. And I'm delighted to discuss with you today recent data about advanced prostate cancer that we have selected. So, to make it easy, I decided simply to follow the natural history of the disease, moving from localized disease, obviously at high risk for relapse, and then biochemical failures, metastatic hormone sensitive disease, and MCRPC will be covered also. So let's start with localized disease. Patients with typically a high Gleason score, T3 disease, and or a high PSA value. One paper we just saw out there is a second analysis, if you will, from the Radicals phase 3 trial that was also published in Annals of Oncology last year. And this is a quite large randomized phase 3 trial looking at two population of patients. And actually, this is, to be honest, this is the drawback from this trial because it's a mix of patients who just had a prostatectomy and they're in, if you will, in an adjuvant setting. So there is a bad news on the prostatectomy specimen, high Gleason score, PT3 disease, something like that. But really, the PSA is undetectable. So you're treating a risk in the setting. And the other part of the population that was enrolled in Radicals is actually that of patients who already have a relapse, a PSA relapse, a biochemical relapse with no detectable metastasis. So 40% adjuvant, 60% salvage, 500 men approximately in total. Question is whether we should use radiation therapy alone, radiation therapy with a short course of androgen deprivation therapy, or radiation therapy plus ADT for 2 years. If you take the trial as a whole, there's simply no difference between these three arms. And this is true in terms of metastasis-free survival and also in terms of overall survival. So you can make your life easy if you want, and you can use radiation therapy as your standard treatment. But having said that, if you're really considering patients who were randomized between ADT 6 months and ADT 2 years, there's actually a difference favoring the longer duration of ADT in terms of metastasis-free survival. And I'm saying that because in this trial, because this was a quite weird trial, well designed, you had the opportunity to randomize your patients between the two first arm, the two last arm, or everything. And of course, if you're seeing a patient at low risk, you may consider randomizing him for radiation alone, for example, versus the same plus ADT for 6 months, but not necessarily ADT for 2 years. On the other hand, if you're seeing a patient at truly high risk and your goal is really already to use ADT, you will select this gentleman only for ADT and you will compare 6 months versus 2 years. So if you're facing a man at low risk, probably it makes sense to use radiation therapy alone as your salvage treatment mainly. Now, if your patient has a high risk, high Gleason score, rapidly rising PSA, something bad, then you may go for 2 years of ADT, not 6 months, because again, radicals suggest that 2 years is associated with a shorter risk of metastasis or death. A second trial was also reported in the Journal of Urology, and this is looking at apalutamide for patients with high-risk localized disease after radical prostatectomy again. But again, these patients have an undetectable PSA. This is a purer population of patients just right after prostatectomy was performed. Again, good news on the PSA. It's undetectable, But bad news on the pathology specimen, you have, say, a high glycemic score or PT3 disease. So there's no comparison in that specific trial, and the primary endpoint was to look at time to biochemical recurrence. Well, you can see that actually there is good news. If you're using a prostatectomy, the PSA is undetectable, and if you're using an adjuvant hormonal agent such as apalutamide with or without ADT, basically, within the short term, at least 2 to 3 years, you don't see any recurrence. So that's great, but it's not, of course, a confirmation or a demonstration that indeed these patients need any form of AR, androgen receptor targeting. And actually, very recently at ASCO GU, we just saw the readout in the long term of a randomized phase 3 trial that we actually conducted here in France, randomizing ADT yes or no in these patients with undetectable PSA, post-prostatectomy, and poor risk features on the prostatectomy specimen. And there's actually no benefit from early intervention in these patients. And this is true regardless of the endpoint you're looking at: biochemical failure, metastasis-free survival, and of course, overall survival. So probably we should just watch most of these patients when they have an undetectable PSA, or we need to invent a better biomarker that can help us select the few of these patients who don't do well if you don't intervene immediately. The second situation I'd like to comment on is that of men with biochemical failure post-local treatment. So as we all know, probably, this is a very heterogeneous situation. We know the natural history of this situation. It's mostly predicted by the kinetic of PSA, so PSA doubling time, and by the Gleason score as assessed on the initial biopsies or the prostatectomy specimen if a prostatectomy was performed. But actually, there is a game changer, which is PSMA PET, which is more and more telling us wherever disease is located, is that a local relapse, is that already metastatic disease, or both? And probably we will need to integrate PSMA PET in the decision making in this particular scenario. But most trials we have at the moment were conducted at times when PSMA PET was not available. And this is what I'm going to show you in this recent publication. So, for example, this is PRESTO. PRESTO was a phase 3 randomized trial looking at androgen targeting agents, so ADT, or combined with an AR pathway inhibitor, which is apalutamide here, in these patients with high-risk biochemical relapses. And as you can see, 500 men were randomized. They had a PSA doubling time of less than 9 months. They had a BCR post-radical prostatectomy. And PSA progression-free survival was actually improved significantly, favoring the apalutamide arms. But at the end of the day, this is PSA progression-free survival, and we probably want stronger endpoint to make a given treatment ready for prime time. This is actually what we had just a year before with EMBARK, which actually first read out at AUA 2023, so almost 2 years ago. And actually, this was really the first trial showing that a meaningful primary endpoint of metastasis-free survival could be significantly improved when enzalutamide is being used. And this was actually true, either using enzalutamide in combination with ADT as compared to ADT alone, what you can see here on the screen, but also when enzalutamide single agent was used and compared versus ADT alone. And this was an intermittent strategy of treatment, which is important to remember. To be fair with the data, the benefit we're seeing with enzalutamide alone is probably not as high as the one we're seeing with ADT combined with enzalutamide. So this is also important to remember. Also, you may think that most of the toxicity comes from the ADT, but enzalutamide alone also has toxicity, including cognitive impairments due to the brain barrier penetration, but also gynecomastia, which can be very annoying in these patients. And that is not that easy to prevent. So important to know. So I took my time on Embark, even if this was shown 2 years ago. And this is because we're seeing now sub-analysis of Embark. And this is now what I'm going to comment about. For example, Dr. Friedland and colleague reported a sub-analysis of a trial looking at sexual activity in these patients. And of course, you may think this is very important from a patient perspective who are just developing biochemical relapse to try to keep their sexual activity as good as possible. So let's review briefly the data. Actually, it's true that if you're using enzalutamide alone, the time to deterioration in interest in sex is better with enzalutamide alone. But the magnitude of the benefit is not fantastically better. This is, if you like to see medians, it's 8.5 months versus 5.6 months. So basically, you're gaining 3 months before your sexual activity really deteriorates significantly. So it's a 30% reduction in the risk. And similar findings were also reported for extent of sexual activity, satisfaction with sex life, which is 11 months versus 5 months, erectile function, approximately 5 months versus approximately 3 months. So again, it is better with enzalutamide alone as compared to androgen deprivation, but it's not fantastically better. So we need to communicate this information to patients before we start treatment, either enzalutamide alone, ADT, which probably should not any longer be used in the setting, at least in my opinion, or ADT plus enzalutamide, which actually do not protect sexual life. Also, in the trial in Embark, we saw important data, I think, sub-analysis looking at age. And this is becoming a very serious thing because, of course, treating patients in the elderly is not easy. And we may actually harm patients with side effects in the elderly, but also they may not necessarily get the same benefit that younger patients derive from many treatments we're using in oncology. But let's review first the data we have in Embark. Here, enzalutamide with or without loprolide, by the way, was tested versus ADT alone in patients with young age versus in the elderly. To the left-hand side of the slide, you're seeing enzalutamide combination with ADT versus ADT alone. ADT is the yellowish curve, while enzalutamide in combination is the blue curve. And as you can see, you see 4 curves to the left-hand side, which are this subgroup of patients by age. And as you can see, the benefit is being seen across the board for patients, regardless as whether they are young or old, which I think is very reassuring and very interesting to us. To the right-hand side, enzalutamide alone in red is being compared versus ADT alone in yellow. Again, 4 curves because you have 2 curves according to the age. And as you can see again, enzalutamide appears to be the winner versus ADT alone. And this is true in younger men, but also in older men, which I think is very reassuring for the practice. we just saw data at ASCO GU, looking at not only data of lutamide, such as enzalutamide, darolutamide, apalutamide, but also those about abiraterone. And it actually appears that abiraterone in more advanced stages does not necessarily improve outcomes, especially overall survival, in the elderly, probably because we are arming these patients from a cardiovascular standpoint. But let's review first another trial in patients with biochemical failure. And this is probably a more modern design. This is the ARASTEP phase 3 trial looking at the role of darolutamide. So this is a scenario, probably more contemporaneous, when you see a patient with biochemical failure. PSA is rising fast, so that's not good news. You do a PSMA PET, and out of a sudden, you realize that there are a few spots. So this is typically oligometastatic disease that we're now seeing with PSMA PET. So it's a brand new situation, somewhere in between the old-fashioned biochemical failure with high risk, similar to what I just spoke about for EMBARK, but also, on the other hand, somewhere, below the oligometastatic disease that bone scan or CT scan would be able to detect. So how best to treat these men? We don't know. We don't really know. So a pragmatic view is to use stereotactic radiation therapy, targeting this oligometastasis progression. Use also systemic treatment because this is already systemic disease. Dissemination is obvious by PSMA PET. So ADT is part of the treatment. But the question is whether we should still intensify systemic treatment with an AR pathway inhibitor, here darolutamide, in this scenario. So there was, actually I can share that with you, there was quite intense discussion and debate within the steering committee as to whether the control arm should be short-term or long-term ADT, and we finally agreed on 2 years. I think this is a pragmatic decision. There is more and more data showing that 6 months may not be enough, but on the other hand, lifelong treatment with ADT is probably just too long, and we want some intermittent treatment for these patients with metastatic relapse, post-local treatment. So this is why the control arm in ARASTEP consists of 2 years of ADT plus stereotactic radiation therapy, while the experimental arm is the same, plus darolutamide. And the trial is currently enrolling very nicely, so we'll see the data. Let me move now to metastatic castration-sensitive prostate cancer. We just saw data at ESMO from an important phase 3 trial, which is the first one looking at the role of darolutamide with ADT alone in these patients with metastatic hormone-sensitive disease. You may say, but we already know that an RP is needed in this situation, which is very true. But unfortunately, this is not necessarily available in many countries. So, and of course, we know that since 2017, thanks to Latitude, Stampede, Arches, and Zamet, all these trials showed very meaningful overall survival PFS benefit. But again, as I said, in many countries, these drugs are not reimbursed, not approved, not accessible to many patients. So this is why this trial was designed and conducted in these countries where ADT remained the standard of care for patients with metastatic disease. So they were randomized to receive ADT alone or combined with darolutamide 6 milligram twice a day. And as you can see to the right-hand side of the slide, clearly radiographic progression-free survival is significantly improved in the combination arm, as was, of course, expected based on previous trial using the same family of agents. Now, regarding overall survival, the jury is out as I'm speaking, and this is because the trial was really analyzed very early because the RPFS was the primary endpoint. You can see that actually the follow-up is more a year and a half, 2 years. So most patients were alive when the trial was first analyzed. We will need a longer follow-up. Probably in 2 years' time, we should have data about overall survival. But I suspect that this will be also improved. So I think this is important. Not only for the populations who were treated in the countries where RPs are not available, but also for other countries such as the US or Western Europe, where we have quite broad access now to RPs. But I'm saying that because darolutamide is very safe, and this was also confirmed in the trial. This is really a drug that doesn't add much of toxicity when added to androgen deprivation therapy. So, to be honest with you, if approved, I would be quite keen to use darolutamide in many patients just because the toxicity profile is so favorable. And this is obviously true in frail patients. Staying with metastatic castration-sensitive prostate cancer, we also saw a sub-analysis of the ARCHES phase 3 trial, which is testing randomly enzalutamide, and which actually established the role of enzalutamide in the setting together with the ENZAMET phase 3 trial. So this sub-analysis look at patients according to age, lower than 75 or more than 75 years. And as you can see to the right-hand side, the benefit is being seen across the board in all these patients, or at least independently of the age, which again is so reassuring because an important proportion of all the patients are actually in the elderly. And as I said before briefly, we just saw at ASCO GU data from a large meta-analysis conducted from academia, looking at the benefit of IR pathway inhibitors in the setting of metastatic hormone-sensitive disease by both PFS and overall survival, but also looking at subgroups depending on whether the RP is targeting the androgen receptor, the lutamides, or whether it's targeting hormones with abiraterone, with CYP17 inhibitors. And as you can see, I think this is very important for our practice. It appears that on the one hand, lutamide indeed prolong life in the elderly, but not abiraterone, which again reflects part of the toxicity we're seeing from a cardiovascular standpoint in the elderly with abiraterone acetate. So, I mean, to me, this is very helpful for my practice. And when I'm seeing a patient, typically older than 75-year-old, I'm now trying to favor a lutamide and not abiraterone anymore, if I can choose, and of course, if there's no contraindication. While in a younger patient, I feel very comfortable using either abiraterone or a lutamide agent, given that the efficacy is very similar, and then abiraterone may have an advantage because it's a generic drug and also quite well tolerated in younger patients. Now, another analysis was performed from the HERO phase 3 trial, which is looking at relugolix. You might remember that relugolix is an oral agent, the first one, which is preventing the making of testosterone by being an antagonist of GnRH, as opposed to leprolide, which is an agonist. So testosterone recovery was assessed in the trial in patients who had stopped drugged. And as expected, given the mechanism of action, we see a marked difference in recovery of testosterone favoring relugolix. And indeed, testosterone recovers very rapidly when the drug is discontinued, while with leprolide, this is a much longer time to recovery, and often you have to wait for years. So that is obviously a very important finding, because in some patients, you're actually keen to go for intermittent treatment, and you want your patient, or the patient wants a testosterone recovery. So, and in those situations, an antagonist is the way to go. While in some other patients, it's the opposite. You really want the testosterone to be suppressed as long as you can. And in these situations, you may decide for an agonist. Finally, I have, or at least we have data to report from Arasens regarding the effect of darolutamide against PSA. And as assessed at 6 to 8 months after the start of systemic treatment in patients with metastatic hormone sensitive disease. And again, we're seeing that PSA is a damn good prognostic factor in these patients with metastatic disease when assessed, again, as I said, approximately 6 months after the start of the beginning of the systemic treatment. Very strong evidence supporting looking at very low PSA value as the target for treatment. This was, of course, achieved more frequently in the darolutamide arm. And regardless of volume, high volume or low volume, we do see that a low PSA is a good thing. So this is really a target for treatment. And actually, this is now getting more and more a potential time for further intervention, or actually potentially discontinuation, or lowering at least the burden of treatment in patients responding well. So you might actually envision a new generation of trials where in good responders, you might actually say, well, maybe I should lower the burden of treatment, but of course we need to randomize data to make sure that this is safe. While on the other hand, for patients not responding well, so those with still detectable PSA at 6 to 8 months, this might be a good time to intervene if, of course, we have treatment to do that earlier and try to prevent the onset of progression and death. And actually, these trials are just starting as I'm speaking, using both strategies, de-escalation and intensification. Probably even, I think, more original is this final paper, which is also looking at this concept of response being assessed by PSA at 6 months' time. But all the colleagues actually looked at two different thresholds. One is the classical lower than 0.2 nanogram per ml threshold of PSA, and they confirmed, as I just showed before, that indeed patients who reach this threshold do better than those who have a PSA greater than 0.2. Okay, that is confirmation. But again, as I said, more original is this second analysis. They actually looked at whether a PSA of 0 is better or not as compared to 0 or in between 0 and 0.2, so very low values. And they could show that indeed a PSA of 0 is even better. So this is again the real target of our overall treatment, is trying to achieve as much PSA 0 values as we can with all our existing treatment and the next to come treatments. So that, I think, is very original and important for further treatment and development in trials. Finally, I won't have data to show because they're not in the public domain, but we have a press release about targeting AKT in patients with metastatic hormone-sensitive disease. And just to refresh your memory, I'm showing this cartoon to show you that approximately 20 to 25% of patients have a loss of PTEN in their cancer. This is actually associated with aggressivity of the cancer. And biologically speaking, it actually stimulates the AKT-PI3 kinase pathway in parallel to the androgen receptor pathway. So if what I'm showing here on the screen is true, and this is what the lab predicts, in these patients, we should actually target both the AKT pathway in parallel to the AR. And actually, this was shown, I think, very elegantly in a randomized phase 2, in a previous randomized phase 2 trial, combining abiraterone with or without ipatasertib, an AKT inhibitor. And as you can see to the left-hand side, in patients with PTEN loss, you do see benefit from the combination, while for patients without PTEN loss, you don't see much benefit. And what was actually shown with 400 milligrams dosing was confirmed with 200 milligram dosing. In patients with PTEN loss, the dual combination is a way forward, while for patients without PTEN loss, it just doesn't work. So I'm reminding this data for you because we just heard from a press release that the Capital 281 phase 3 trial is positive. And this is a trial looking at this exact same concept in metastatic hormone-sensitive disease, and it combines abiraterone with or without capivasertib, which is also an AKT inhibitor, actually approved for patients with breast cancer. And the primary endpoint of radiographic progression-free survival is being said to be significantly improved, which is great. So we just need now to see the data in the public domain, so very likely in a soon to come Congress. And of course, it will be great to discuss the data and see whether the magnitude of the benefit is sufficiently important to justify use and whether this comes or not together with secondary endpoints. And this is actually the press release that just came out a couple of months ago. So this is it, and I thank you very much for your kind attention.